so much, Tanya. Thank you, Tanya. My name is Ron Pinkerton. I am the care navigator here in the Birmingham area. I have the pleasure of introducing our guest speaker today. We're so thankful that each of y'all have joined in for this particular segment on the deep brain surgery, or deep brain stimulation, excuse me. And this is part two of a three-part series. So we certainly hope that those that are participating today will be involved with that again this upcoming week. Um, as I am just honored to introduce a gentleman named Mike Tapley. He is a deep brain stimulation consultant at Medtronic. His role is to help patients with neurologic disorders improve their quality of life through a truly innovative and effective brain stimulation therapy system. He partners with neurologists, neurosurgeons, hospital administrators to develop and implement customized therapy programs. He takes his expertise into the operating room and into the clinical technology deployment, also direct to patient education, and also into the administrative offices of the hospitals then too. He actually serves on our board at the Parkinson Association of Alabama as chair of the development committee and is a truly integral part of our organization. So with that, what I would like to do is just introduce Mike and let you take it over at this point.
Good afternoon, Ron, and good afternoon to all of our webinar attendees. My name is Mike Tapley, and I'll be presenting today on DBS, or Deep Brain Stimulation. Before we get started, something that I discussed with the team at Parkinson's Association of Alabama is that it's really important to me to disclose the nature of my professional designation, given the great trust that Parkinson's Association of Alabama has placed in me to present to you, and out of respect for you, Parkinson's patients and caregivers on the call today. I am Medtronic's senior therapy consultant in the state of Alabama. That is a very fancy way of saying that I work for Medtronic's DBS sales division. I'll be talking today about DBS in general. We'll go over some of the things that Dr. Bentley discussed last week about DBS in general, but I'm also going to be talking about our technologies, specifically some of Medtronic's proprietary technologies that have evolved dramatically in the DBS space over the past 25 plus years. One thing that I really feel like I need to tell people is that anytime you are talking to or listening to an industry representative such as me, we have a duty to portray our brand, in this case Medtronic, in the best light possible. I've been doing this a long time, and advancements in Parkinson's care, including DBS, are ongoing. I'd encourage you to inform yourself about all therapy options by consulting your physician. I often get the question, why should I turn to one device or the other? And I tell patients that if you're considering DBS, think of your neurologist and your neurosurgeon as Tiger Woods or whoever your favorite golf champion is. You would not instruct Tiger Woods on his club selection in the middle of the Masters or something like that. And telling a physician which system you want is a lot like telling Tiger Woods to go and play golf with your grandfather's old wooden clubs. It doesn't necessarily work out to your advantage to dictate device choice. Having said that, I am with Medtronic. There's a reason that I have been with this company and stayed with this company for as long as I have, and I'm honored today to be able to talk to y'all about deep brain stimulation. So we'll go ahead and get started here. A little bit about me and what I do. In May, I'll start my 18th year with Medtronic's Deep Brain Stimulation division. In that time period, I've had the honor and pleasure and good fortune to have attended and been in over 1,700 DBS wire placements or brain procedures, over 6,000 DBS battery surgeries, so everything related to implanting the DBS battery that we'll talk about later, and well over 5,000 DBS programming sessions. I work primarily with the neurology and neurosurgery teams here in Birmingham at UAB, but I've helped start several DBS programs from Georgia to Mississippi and on the Gulf Coast. Um, my personal cell phone number is 205-306-4019. Again, that's 205-306-4019. And my email here, I've put it in here. These contacts are available if you have a question that you don't want to ask in front of the whole group. You can also, again, find a recording of the presentation on PAA's website after this. During this presentation, if you don't want to speak up or ask a question out loud, you can use the chat feature on the Zoom window here to actually post questions during the webinar. I have about 20 slides to go through. I don't like the formality of slides, but they do help us get along through our conversation and move towards a practical end. But we'll go ahead and get started and look forward to talking all things DBS with everybody today. So first of all, I'd like to focus on your questions about DBS from a device standpoint. But for those who might not have attended last week's webinar, we're going to take a glimpse at life with Parkinson's, what DBS is, when to consider it, what to expect. And I might even have a few videos in here that will play. And these are from patients that have received deep brain stimulation therapy for Parkinson's disease. I want to kick off with a short video. This is about a minute long, and this is a gentleman who had deep brain stimulator surgery performed. He's a younger patient, so one of our young onset patients, and this is a great way, I think, to open the meeting and just have you listen to this. And if you have any questions or anything, start to write them down or put them in chat.
Mike, I've got no audio on this.
Okay. All right. So I'll walk you through this. This patient is talking about they're talking about the fact that they started shaking and they learned that that they had Parkinson's disease. And here you see a part of the video showing the patient with his neurologist and the tremor prominent in his left hand. Soon you'll see Edwin here after his device has been turned on, and you'll just see that his tremor is gone. In fact, we just saw that. Sorry, the audio didn't work out there, but the message here is that DBS can have a profound impact on some of the cardinal motor symptoms of Parkinson's disease. So I'm going to go ahead and progress to our next slide here. Now, first of all, I know that anybody on this call that has Parkinson's disease or who is a Parkinson's caregiver, you're already experts on what it's like to live with Parkinson's. I do like to start out with a quick summary of what most people deal with in Parkinson's. I find that useful. So let's talk about it. So Parkinson's is highly personalized. A myth out there is that every person with Parkinson's disease experiences the same symptoms. And the fact is that Parkinson's disease can look extremely different from one patient to the next. Parkinson's is so personalized that every patient has a different mix of symptom timing and variability. And this change in Parkinson's disease throughout the day and the week is constant and persistent. The most common symptoms and the symptoms that DBS happens to be very good at treating are tremor, slowness of movement, we have stiffness, and the timing again of these symptoms comes and goes differently with each patient. And because of this, DBS requires a very personalized approach to management, whether you have DBS or not. As you well know, Parkinson's disease, or you'll hear me call it PD, it affects aspects of daily living that people without Parkinson's, like me, take for granted. The simplest of things, whether it's turning the pages in a book or some of the things that are described here on this slide. Parkinson's disease. Parkinson's disease is always with you, and those symptoms go up and down through the day. So medications are typically our frontline therapies in our arsenal to alleviate symptoms of Parkinson's disease, and they're wonderful. And one of our primary medications is carbidopa-levodopa, but medications do have a number of limitations and side effects. One of the things to understand about medications is some of the things that do limit it, and that is that over time you might require increased dosage to increase the effectiveness of the medication. You might develop involuntary movements. If anyone has ever seen Michael J. Fox, who's done so much for Parkinson's disease, you'll see that he has a lot of involuntary movements. These are called dyskinesias, and these movements arise after you've been on carbidopa-levodopa for some time in many people. There are other side effects of medicines that each of you can likely attest to. So carbidopa-levodopa, I'm just going to focus on it just for a moment. It comes in many brand names, such as Sinemed or Rytary. And carbidopa-levodopa is the most common medicine for Parkinson's disease. And this class of medicine replaces the dopamine that is naturally produced in a non-Parkinson's brain. But it does so through the oral route. So you take a dopaminergic medicine, it breaks down in the stomach, and eventually it arrives in the brain. And it helps to restore motor function. But because carbidopa-levodopa is taken orally and the dopamine available to the brain does fluctuate, this causes up and down symptoms during the day. And we call the ups, so when things are going well, we call the ups on time and the downs off time. And many people also will get dyskinesias when they're in that up or on time. And these irregular movements are thought to arise as a function of orally administered dopamine not being taken up by the brain the same way as naturally produced dopamine comes from the brain and facilitates movement. Bottom line, most people with Parkinson's experience a very personalized version of these on and off swings and dyskinesias during the day. So let's fast forward to DBS. And the reason I fast forward to that is that we discussed last week quite a bit, sort of the process of getting to surgery. And I don't want to stay on that topic too long, but if your Parkinson's specialist thinks that you're a good candidate for DBS, you can expect more hours of on time, typically a reduction in your medication burden, and overall better quality of life. Part of this is because brain stimulation, and we'll go through the devices here momentarily, but brain stimulation is present in your brain 24 hours a day, 7 days a week. It's not subject to the waxing and waning of medications because it is electricity delivered directly to specific targets in your brain that help you with the motor symptoms that we discussed earlier. So, one of the things that I remind patients who are dealing with Parkinson's is that now more than ever, there is an arsenal of very powerful tools that are at the Parkinson's specialist's disposal to manage your DBS symptoms and personalize your therapy so that you can get the most out of life, even with the limitations that Parkinson's imposes on you. And the main thing that I encourage people to do is, in order to bring these tools to bear, uh, there are specialized Parkinson's neurologists who have extra training and expertise in movement disorders. By seeing a movement disorders specialist or a Parkinson's specialist who's fellowship trained in movement disorders, you can be assured that all of the latest tools are considered in a personally tailored way for you. And these tools, there are new things coming out from a medical therapy standpoint, surgical intervention standpoint, and of course, device intervention standpoint, which we're talking about today in DBS. A couple of notes on eligibility. Again, I encourage you to consult your Parkinson's specialist regarding your eligibility, because each person with Parkinson's is unique. But generally speaking, if you've had Parkinson's for more than 4 years, if you've had movement symptoms or medication side effects for more than 4 months, if you are a good responder to carbidopa, levodopa, or Sinemet, Rytary, there's a lot of brand names out there, or if you have movement symptoms that aren't adequately controlled by your medication, you may be a candidate for DBS. And again, discuss that with your Parkinson's specialist. So generally speaking, people will ask me about DBS, and like we're doing today, we're focusing on the devices. We'll get into that here soon. I noticed that many Parkinson's patients who are considering DBS put a tremendous amount of focus on the surgery, and that's understandable. The surgery itself can seem quite scary and daunting. But the interesting thing about DBS is that DBS, the DBS surgery is more of a snapshot in time. Once the DBS is implanted, the surgery is a fraction of the amount of time that you'll have to actually experience the DBS journey. And so people focus so much on the surgery, but after the surgery, everything comes down to personalizing the therapy, and making the medicines and the deep brain stimulator work in conjunction with each other. So I would just encourage people to understand that the surgery is a critical component of personalizing the therapy, but the goal of surgery is so that you can live the rest of your life with the DBS system and have it hyper personalized to your therapy needs. And ultimately, like many things in life, the DBS is designed to be adjustable so that we can meet you where you are in your current state. So there are a number of tools that we can use to tailor your deep brain stimulator to your specific personal situation. This is an overview of the typical DBS surgery steps. I don't want to overwhelm you with surgery, but these are the surgery steps. Now I'll customize this a little bit more for people who might be considering having DBS done in Birmingham, Alabama. You'll typically have the DBS wire or lead placement. If you're looking at the picture on the left, it's a sort of a cartoon of the deep brain stimulation systems in the head. You'll have that wire placed in your brain either Monday, Tuesday, or Wednesday, depending on the surgeon that's doing the procedure. And you'll spend one night in the hospital after that. And in most cases, on that same Friday, you'll have your DBS battery placed. It will typically be located just below your collarbone, and 1 or 2 wires will be run under the skin to connect what we call the brain wire. And I'll put this up in the camera. It's a very thin wire, but we call it an electrode or a lead or the brain wire. You'll have that wires run to that under the skin, and connect all of that to the battery pack, the DBS battery pack. And then you'll go home on Friday after the second surgery. you'll be sent home to recover for a few weeks. In some instances, we'll actually turn the deep brain stimulator on that Friday so that you get some relief of your symptoms. And then you'll be sent home to recover. And that can be 2 to 6 weeks, depending on your individual situation. But then you will actually have the system programmed. So now I'm going to get specifically into the DBS device. Again, for those of you that might have just joined the call, Dr. Bentley from UAB actually presented on the DBS surgery. So if you weren't able to be on that webinar, take time to reference it on the Parkinson's Association of Alabama's website because it deals with aspects of DBS from a clinical and surgical perspective. But let's just focus now on the pieces and parts of this deep brain stimulator system. So quite simply, deep brain stimulation is the delivery of electricity into precisely targeted areas of the brain via a small wire that is powered by a battery and computer pack that is very much like a pacemaker. And all of these devices, again, are implanted under the skin. The working end of the deep brain stimulator is called the lead or the electrode, as I mentioned before. And I've mentioned several times that Parkinson's management is highly personalized. In DBS wire placement, so in the part of the surgery where we put this electrode in the brain, the lead placement is hyper personalized. And that's because every brain is unique and the anatomy of your brain is different than the person sitting next to you. The Medtronic lead has a couple of attributes that help to fortify the personalization of the deep brain stimulation in the chronic phase, so after the surgical phase. One of those is that we can actually send out stimulation in one direction by using some of the contacts that are on the end of the deep brain stimulator lead. Here on the right side of the screen, you're going to see an actual picture of our deep brain stimulator lead. And there's an array of 4 levels of contacts made out of platinum and iridium. And there's a grouping of contacts that are segmented. They're actually individual contacts, and they can be selected radially around the lead to send stimulation towards favored anatomy and away from anatomy that might cause side effects. Secondarily, a very unique capability of this lead is called the Medtronic SenSight lead, is that it's not only designed to stimulate the brain, but this lead is also manufactured using proprietary insulation and manufacturing methods that allow us to actually detect your personal brain activity. This is a very unique capability, and it's closing in on a capability that allows us to actually listen to the brain and then respond with stimulation that changes as your brain activity changes during the day. So this capability allows us to basically track the personalized fluctuations in your symptoms that can be expressed through a brain signal. And that can help us in multiple ways. It can help us by identifying potential starting points for programming the deep brain stimulator. And finally, they can be used with our newly FDA approved adaptive capabilities to regulate stimulation according to fluctuations in brain signals throughout the day. It's amazing technology. I can't believe that I'm actually witnessing right now the launch of this particular technology. But instead of screaming at neurons with stimulation, we're now able to listen and react to neuronal activity. And I've always thought that talking was less powerful than listening, even though I've done a lot of talking today. So that's the business end of the DBS device. And in a general sense, we have the other end of the device, and this is called the battery pack in layman's terms. And what you're seeing here is Medtronic's fourth generation of battery packs. As the first company to manufacture DBS systems, we've had to come a long way in advancing the therapy. So we had an original generation, and now we're to our fourth generation. The original generation, we started implanting those in 1997. But here you see our latest family of battery packs. Now, in industry or in clinic or in neurosurgery, we call these battery packs implantable pulse generators because that's what they do. They are implanted and we generate electrical pulses with them. We also just use the term or the acronym IPG. And again, these two IPGs are our latest IPG family called the Percept family. And the family of Percept IPGs includes two different devices. One is a non-rechargeable IPG called the Percept PC, and the other is a rechargeable deep brain stimulated called the Percept RC. And if you might be able to see them there on the slide, but here's an actual Percept PC, primary cell or non-rechargeable. And then here's a Percept RC or rechargeable device. And the main difference that you see here is size. The functionality is exactly the same. The devices both have the ability to listen to your individually identified brain activity, and if appropriate, and when configured appropriately, they can adapt stimulation based on that signal. So each implantable pulse generator or battery pack has its place. Your Parkinson's doctor and your neurosurgeon will weigh in to decide which system is appropriate for you. And generally speaking, again, I would urge you to listen to their advice. Generally, DBS batteries across the spectrum are either rechargeable or non-rechargeable. A non-rechargeable battery is typically denoted with the term PC for primary cell, though sometimes people refer to these batteries as recharge free. What that means is that battery will typically have a life of anywhere from 3 to as many as 10 years, just depending on the use scenario, whether 1 or 2 wires are plugged into it, things like that. The rechargeable devices last longer. So one thing that I do want to bring up about rechargeable technology is attractive to many people on the surface because those devices are small and thin. And the Medtronic rechargeable device is designed to last at least 15 years. And we can make those claims just because we actually are the only manufacturer who produces our own battery chemistry and power supply units in-house. So it gives us a unique understanding of our battery chemistry limitations. But rechargeable systems aren't for everybody. It does require maintenance on the part of the patient and the caregiver team, and it is not the perfect thing for every single patient. And again, this goes back to talking to your physician about appropriate device selection. So those are the two basic pieces of the deep brain stimulator system, and oftentimes there's some confusion about the overall components of the implant system. The two components that don't get mentioned very often, but I do want to bring up is that after DBS, you'll have a slight bump on your head wherever the brain wire has been inserted, and that's because there is a clip that holds the deep brain stimulator wire in place on the skull, on the surface of the skull. And then finally, there's a critical component called the extension wire. And the extension wire, I have one here. It is actually used to bridge the gap between the head and the chest, and it's connected to the lead wire on one end, so the brain lead wire, and then the deep brain stimulator implantable pulse generator, whatever you want to call it. And that extension wire, usually you can feel a piece of it in your neck below the skin. But one of the reasons people ask me why you're awake for the brain surgery, but in most cases, but asleep for the actual placement of the deep brain stimulator device. And the reason that we have to put you to sleep for the placement of this wire is that we actually have to tunnel it under the skin, and it would be very difficult for a person to tolerate that while awake. They would be a mighty tough human being. So a few things about living with DBS, and just I'll wrap up the discussion and answer questions. People often ask, what activities they'll be able to participate in. You can talk to your doctor about it, but the restrictions are fairly minimal. You don't need to go bungee jumping or jumping out of airplanes because high G forces could damage the device. Uh, you can definitely travel with a deep brain stimulator. MRI access is available with the systems. It's interesting. One of the things that I'm particularly proud of is that the Percept family is actually it actually allows you to have MRIs with the more powerful 3 Tesla magnets now that give better image quality. And finally, the question often comes up, can I check my DBS battery or change the programming settings? And the answer to that is absolutely. You will be equipped with a deep brain stimulator programmer. It's basically a Samsung phone that interfaces with this communication module, and that allows you to issue commands to your deep brain stimulator to increase or decrease your stimulation, change the programming, check your battery status, things like that. So I just want to show a quick video clip here. There's no audio here, Ron, so we should be good. But here on the left, you see a patient who has their DBS turned off with no medication. And then I'm going to click here and you'll see, well, I want to just review this. So this is a Parkinson's patient that's experiencing severe off symptoms. That step pattern is called festination there on the left. But over here with the DBS on and no medications, you see that the patient is not experiencing that hesitation of movement. And it's a pretty stark difference. And again, that's with no medication in that particular case. Again, that's a pretty young patient. So that's really the end of my presentation. Here you can scan this QR code to access Medtronic information. You can use it to join our Facebook page and find centers that offer DBS therapy in your area. We just encourage people to, if you're being seen by a general neurologist, ask them about DBS. If they haven't talked to you about it, they can actually refer you to somebody that manages DBS and is a specialist in that area. But just know your options. Know that there's a large arsenal of tools to help you in your Parkinson's journey. I have just some disclaimers that I have to put up here. So DBS therapy for Parkinson's disease has established long-term safety and effectiveness over a 36-month period. DBS is contraindicated for patients who will be exposed to deep heat treatment called diathermy or transcranial magnetic stimulation. And the potential risks, as Dr. Bentley alluded to last week, of having a DBS system can include bleeding, stroke, seizure, and infection. With that, I will go ahead and quit talking, open my ears, and answer any questions that might be out there.
Mike, first off, we want to thank you for your expertise and you joining us and enlightening us on all of this. Thus far in the chat, there are 2 questions from Monica. One is there an age cutoff where it would be considered unsafe to use DBS? And then the follow-up question by her also, is the device fully covered by Medicare?
So I'll answer that in reverse order. Medicare covers the implantation of deep brain stimulation systems. It's FDA approved, so definitely can Medicare can cover it. And the original question on age, so there is no specific age limit, and anecdotally, the answer that I have seen many of the physicians who I work with on that question is that age is less a number and more a physiological state. I've seen patients in their 80s receive DBS. I have patients in their 90s now who have had DBS for a long time. And DBS is done for I've seen DBS done on patients in their 20s who had very young onset Parkinson's disease. So age, get talk to your neurologist and your neurosurgeon about uh, about whether or not somebody's a good surgical candidate, and they will give you an idea of whether or not age is a limiting factor. Typically, it's not. It's just what level of well-being that patient is at.
Thank you, Mike. What we would like to do, and Monica, thank you, very good questions on that too. What I would like to do is give a couple of more minutes for people to insert any questions that they may have in the chat. And then in the meantime, also remind everyone that has participated in this, you will receive a post via email that will give you a follow-up link to this particular seminar so that if you want to go back and review that, you certainly can. And also want to re-invite everyone to please be a part of the next one, which will be next week on Thursday also. And, just want to thank you for taking time out of your day to participate in this. It's really good information. So what I'd like to do is just give another minute or so and see if we have any other questions that populate over on the chat. I have personally talked with a number of patients as a care navigator that have had the DBS implantation, and it has made a massive, massive improvement in their life, in terms of the quality of their life. Here's a question also too. What are the long-term costs of managing a DBS device? Mike, can you address that?
The long-term costs, I think you could summarize that in terms of if you have to have the battery replaced, any copay that might be associated with that surgical encounter would certainly count as a cost. And then the other costs that are incurred are transportation costs between your home and the place where you're receiving programming, but there's no subscription or anything like that. The costs are typically associated with each occurrence of a care encounter. DBS programming by your neurologist is also covered by Medicare and major insurance. So the cost is generally limited to the cost of fuel, transportation, and then anything that you have to pay from a copay standpoint.
Very good. Thank you. I see that Tanya, who is on the backside of this meeting, making sure everything runs smoothly, has already inserted the link for the for next week's program. We'll give it one more minute before we bow out. But once again, just want to thank everyone for their time and their participation. Without you, these are just conversations that reach nowhere. And we thank you for your questions that you've got, and then the expertise that's been expressed already. Thank you, Tanya, to you for all of the work that you've done to make this happen for us. And with that, I see nothing else populating. So, as we like to say in the auctioneer's business, going once, going twice, going three times, and we'll thank you all. Oh, here's a question. Um, Dale Jones is starting to ask a question. You said people have been taking and then unfortunately, Dale, your question has dropped off at that point. So if you want to finish populating that question, and then we'll wrap it up. Um, there's another question here. Now, what new advancements is Medtronic's working on for the DBS? And then we'll finish up with one more question after that.
So the latest advancement, that's a fantastic question. It's one of my favorite questions to answer. Our latest advancement in DBS was our recent FDA approval of adaptive DBS. So this is a technology whereby we can listen to specific brain signals associated with Parkinson's disease, and then tailor stimulation in real time to that signal, so that our batteries adapt to stimulate your brain as your symptoms come and go. And we use a feature called Brain Sense to do that. And it's very interesting. DBS used to be a static therapy where we would literally just send you home, let's say, with 3 volts of stimulation. And that's what your deep brain stimulator would run at. But we now have the capability to literally float the therapy level to tailor the deep brain stimulator to your needs.
Okay, very good. All right. Dale's question has finished up. It said, you said people have been taking the medicine for 4 years. Does that mean you have to have 4 years before needing the DBS itself?
So first of all, if you've been taking the medicines for 4 years, my assumption is that you are being managed by a neurologist. If you start to have motor fluctuations, so up and down symptoms, if you start to have dyskinesias, things like that, that's typically a good indicator that the discussion about DBS is something that ought to be brought up. And if you're not hearing about it, you might want to consider arming yourself with information that's available on deep brain stimulation and bringing it up to your physician.
Very good. Thank you, Mike. Last question, and then we'll curtail this. How many programming sessions are needed to be able to get the DBS appropriately tuned up, so to speak?
Most Parkinson's patients, this is based on my personal experience over the last 18 years, most Parkinson's patients can count on 3 to 6 visits in their first year for optimization. It's highly variable depending on the complexity of Parkinson's that you're dealing with. But I would count on 3 visits. That would be your initial programming session and a couple of follow-up sessions to optimize therapy. And our hope is that through the adaptive algorithm that we have, that we can make that number smaller over time.
Very good. All right. Well, very good, guys. I just want to remind everybody to please join us again next week. Thank you all for your participation, and we'll see you on the next go around. Thank you.